Hi there, my name is Jeff Solheim, and welcome to MedEd's production of the TCRN exam review. You're about to watch the module on chest trauma. Now, if you've looked at the blueprint for the TCRN exam, and we talk about the blueprint in the opening lecture of this series, but if you look at the blueprint for the TCRN, the largest area on the test is called trauma to the trunk. And chest is going to be one of the sections in trauma to the trunk. We've actually broken this module up into several different lectures because they were so long. So this will be chest, but there's also a series on abdominal trauma, there's one on genitourinary trauma, and there's one on obstetrical trauma. And all of those together make up trauma to the trunk, which is the largest area on the exam, the most number of questions. So with that introduction, let's get after it. Now, if you've been watching this series, you'll know that I designed this lecture around what I call challenge questions. So what I do is I give you a question that'll look very much like what you'll see on the TCRN at the very beginning of material. And the idea is that you try to figure out the answer to that question. And then, after you've tried to figure it out, I'll go over the material with you, and then we'll return to the question later to see if you got it right. So it's kind of like a pre-test. Now just remember, I put all the challenge questions at the end of the handout. So if you have the handout, you'll want to turn to the end to look at these challenge questions, to mark the correct answer, to take any notes. It's kind of like you're getting a free practice test out of it. So on the screen right now, you can see our first challenge question. Let's go through it. I'll read it to you. The following rhythm strip is noted on the monitor of a traumatically injured patient. Which of the following injuries does this patient most likely have? Of course, your choices are A, fractured sternum, B, cervical spinal injury, C, ruptured diaphragm, or D, pericardial tamponade. Now, if I were you, I would pause this for a moment and consider the question, come up with what you think is the right answer, and I'll give it to you a little bit later, and then you can see if you got it right. Do you think you know it? Okay, let's get into the material. So what I want to do today as we get into chest trauma is start with fractures, and we're going to look specifically at rib fractures. Now when you look at the rib fractures on the TCRN exam, what you have to consider is that rib fractures are as much about the underlying trauma as the rib fracture itself. So as we go through rib fractures, I'm going to spend a lot of time on the anatomy of the chest because, again, when you have a rib fracture, it's more about considering what's under those ribs than the actual rib itself. So let's start at the top and go to ribs 1 and 2. Think about it for a minute. What lies under ribs 1 and 2 at the top? What structures would likely be injured if you fractured ribs 1 and 2? Can you think of anything? Well, of course, the lungs are under there, right? The upper apices, so there could definitely be lung trauma. But the bigger thing you're going to worry about with those upper rib fractures are the big vessels, the subclavian artery and vein. And even to a lesser extent, you've got like the aorta up in that area, the aortic arch specifically. You have your vena cavas. And those types of things are going to run in that upper chest area as they either return or leave the heart. So when you've got fractures of ribs 1 and 2, you always have to consider the possibility of great vessel damage. Also, especially in the mediastinal area, you've got things like the trachea and so on in that central area up there. So when those two ribs are fractured, those are the kinds of injuries you have to suspect. Lung injuries, injuries to the great vessels, injuries to the trachea and some of the other mediastinal structures near the top. Did you know that ribs 1 and 2 are the shortest and the strongest ribs that we have? It's really difficult to break those two ribs. In fact, if one of those two ribs is broken, the mortality rate can be as high as 40%. And that's twofold. Number one, just because they're so short and strong, it takes a lot of force to break them. So they're rarely ever an isolated injury. They're often associated with other injuries. But also, because the great vessels are up there, the great vessels are often injured, which then in turn leads to a secondary life-threatening complication. In fact, if you look at the picture on your screen right now, I have shown you a picture of the upper area of the chest. Now notice how that first rib, the one at the very top, is down low, and then the clavicle's above it in the picture. I've got that circled. But notice what lies between the first rib and the clavicle? Well, your subclavian and an artery and a vein, right? So to break the first rib, you got to break through the clavicle. The clavicle's got to break down against the first rib, and that's most likely going to disrupt that those great vessels, the subclavian artery and vein. And when those are disrupted, we get hematomas in the airway, and we get hematomas in the chest, and that can lead to hemothoraces. So again, just to finish this up, fractures of ribs 1 and 2, really high mortality associated with lung trauma, tracheal trauma, great vessel injury, and even vertebral fractures. Now let's move down now to ribs 3 through 9. So what lies under ribs 3 through 9? Well, lungs, right? That's the main thing. And to a certain degree, you've got a little bit of heart there on the left side under there as well. So we would mainly anticipate lung injury with ribs 3 through 9 on either the right or the left. And then you also have to consider the possibility of a cardiac injury as well. So most of the time, ribs 3 through 9 are going to have injuries such as hemothoraces, pneumothoraces, pulmonary contusions, lacerated lungs, and things like that. Now let's keep moving down. How about ribs 10 through 12? But let's look specifically at the right. So 10 through 12 on the right, those rib fractures would be associated with? Pretty obvious here, right? Liver trauma. But remember, you can also break your ribs in the back. So if you broke ribs 10 through 12 in the back, then what injury would you suspect? The kidneys, right? The kidneys lie right under ribs 11 and 12. So if you have posterior rib fractures, your patient can also have kidney injury. Statistically, about 10% of people who break either rib 10, 11, or 12 on the right are going to have a liver injury. Now this isn't a hard question, but what lies under ribs 10 through 12 on the left? The spleen, right? And then of course in the posterior area, the kidney. So about 20% of people who fracture ribs 10 through 12 on the left will have splenic injury, and then those that fracture ribs in the back could have kidney injuries as well. The other thing we should talk about here is sternal fractures. What if somebody fractures their sternum? Then what injury do you suspect? That's going to be mainly a blunt cardiac injury and then mediastinal trauma, right? So we'd expect the heart to be injured because it's right underneath the sternum. You could have pulmonary trauma. And then think about the structures that lie in the mediastinum, your esophagus, your trachea. Those are vulnerable as well. So again, let me just say that when you have rib fracture questions on the TCRN, not only do you have to think about the rib fracture, but you also have to consider the structures underneath and what other injuries would be associated with those. Now let's talk about a special rib fracture of note, and that's what we call the flail chest segment. A flail chest segment is where you fracture 3 or more ribs in 2 or more places, giving you a free-floating segment of the chest. You can see a great video of a flail chest segment playing on the screen right now. And in that video, you can see paradoxical chest wall movement. Remember what that is? Paradoxical chest wall movement is where the fractured rib segment sinks in during inhalation. Now remember, normally the chest expands during inhalation, but the flail's going to sink down in like you see in the video. But then during exhalation, when the chest falls, the flail segment's going to bulge. So you got that flail segment doing the opposite of what the rest of the chest does. Now the significance of that is, number one, it does help you be able to identify a flail chest segment. But also what that means is that the lung's not going to expand appropriately underneath that segment, and there's going to be reduced gas exchange in that segment of the lung. So if you have a really large flail chest segment like the gentleman in the video does, you can have some pretty significant alterations in gas exchange because that whole area under there is not contributing to gas exchange, and so you're having a reduced gas exchange. All right. So what is the treatment for rib fractures? Well, your highest priority generally, besides dealing with the associated injuries, of course if they have great vessel injuries or tracheal injuries, that's your priority. But for the rib fracture itself, the highest priority is going to be pain management. And the reason for that is because if the patient is in pain, they'll tend to guard, they'll tend to splint. And when they guard or splint, they're going to reduce their respiratory effort. And that's going to decrease gas exchange, and that can lead to secondary respiratory complications as well, like pneumonias and other infections. So if we can be really aggressive with pain, number one, we can improve gas exchange, and number two, we can reduce the risk of secondary pulmonary complications. So when you're, if you might be asked a question along the lines of what would be the highest priority, pain management really comes in here as one of your highest priorities. And that can, be anywhere from something as simple as oral or IV analgesia to more aggressive pain management techniques like epidural anesthesia, intercostal nerve blocks, interpleural anesthesia, even internal fixations. But all of those will help to control the patient's pain, which in turn will improve their oxygen status as they take deeper and more robust breaths. Now, of course, while pain management will help to improve their oxygen status by decreasing splinting and guarding, we can also assist the patient's oxygenation by supplemental oxygen. We may consider non-invasive ventilation like CPAP. And for some patients, especially with underlying injuries, they may require intubation mechanical ventilation. Now, one thing I am going to talk about here that you're going to hear me talk about several times throughout this chest lecture is the concept of euvolemia, which just means normal volume. Now, if you've watched the special considerations module of this series, I talk about the importance of aggressive fluid resuscitation for hypovolemia, and I don't want to minimize that. But as we talked about in that module of special considerations, fluid, while it helps to maintain the blood pressure and improve oxygenation, it will also tend to leak. And if it leaks with lung injuries, it can lead to secondary acute respiratory distress syndrome, ARDS, which we'll talk about in a few moments. But that brings us to the point that when you're fluid resuscitating somebody with known chest injuries, you have to be really careful not to give them too much fluid, because any fluid that you give above and beyond what they need will contribute to ARDS. So your goal in fluid resuscitating the trauma patient, but especially the chest trauma patient, is to make sure you don't over-resuscitate, that you just resuscitate them back to their normal volume, or euvolemia. Now, some long-term strategies that we consider for rib fractures are really going to be focused on reducing secondary chest complications, like reducing the incidence of pneumonia. So getting aggressive chest physiotherapy, like postural drainage or percussion and vibration, that'll help to loosen secretions and help the patient bring them up so they don't get secondary pneumonias. Because remember, with rib fractures, they may be reticent to cough, so they can't move those secretions. So we want to get chest physiotherapy early to reduce those complications. Frequent suctioning, again, because the patient's going to be reticent to cough, so they won't bring that stuff up. We have to get it out of there. And then early mobilization, and that'll help to reduce the incidence of pneumonia. That's going to be an appropriate intervention for all patients, but especially for our patients with rib fractures who, again, may not be coughing and moving their secretions. All right, that's enough for rib fractures, don't you agree? Let's move on now to great vessel injury. So on your screen and in your handout, I've listed a number of mechanisms of injury that are associated with great vessel injury. Now, of course, almost any mechanism to the chest could injure the great vessels, but things like penetrating trauma, motor vehicle collisions, ejection from the vehicle, falls from greater than 10 feet, and auto versus pedestrian incidents are all associated with great vessel injury to a higher degree. So anytime you have those mechanisms involved, you're going to want to kind of increase your index of suspicion for great vessel injury. Now, this probably comes as no surprise to those of you watching this video, but the survivability of great vessel injury is not great. If we look at the aorta, for example, 80% of people with aortic injuries will die on scene. They won't survive. The aorta tears, the patient exsanguinates within minutes, and even before EMS gets there, they may have already expired from exsanguination. However, about 20% of patients with aortic injuries will survive to the hospital. You might ask, how can somebody survive with an aortic injury? Well, remember, not all aortic injuries completely rupture the aorta. If it ruptures, you probably won't survive. But you could have tears in the intimal layer that don't go all the way through the aorta and give the patient, an injury that would be similar to a dissection. And those types of injuries may be survivable, at least for a period of time. But with that being said, the news for aortic injuries is not good even if you survive to the hospital. If we look at statistics, of the 20% who actually survive to the hospital, 6% of those patients will be dead within 6 hours of arrival. 8% will die within the first 24 hours of hospitalization, which means that only about 6% of patients with aortic injuries actually survive to discharge. Now, you can probably figure this out, but one of the reasons why so many of those patients die in the first few hours is because the clamping of the aorta that's required to repair it can cause significant hypoxia to the tissue, and then that in turn is going to lead to the complications which will cause the patient to die even though they survived to the hospital. So overall, aortic injuries have a very, very low survival rate, but we have to remember that about 6% will ultimately survive, so we need to treat each patient accordingly. Now, as you get to some of the other great vessels, they also have a high death rate, but maybe not quite as high. For example, if we look at the major pulmonary artery and vein, about 60% of people who injure those vessels are going to die, but the survival rate is a little higher with those. Who's the most famous example of somebody who died from a great vessel or a pulmonary artery rupture or laceration due to trauma? Anybody remember? Very famous person, Princess Diana, right? She had an injury to her pulmonary vasculature, but remember, she survived for, I want to say, an hour or an hour and a half before she died. And they tried desperately to save her on scene, but unfortunately her major pulmonary vessels were injured and she would ultimately succumb to her injury. Now, when we look at these great vessel injuries, there's some different types of things that you may have to deal with when the patient gets to the hospital associated with great vessel injury. Now, the obvious one is if the aorta or the other great vessels actually rupture or tear, you're going to have massive blood loss and massive exsanguination. If you're looking at this video, look at the upper left picture, that widened mediastinum, a huge amount of blood that's leaked from an aortic injury into the mediastinal area. Now, sometimes that blood can leak into the pleural space and the patient can get a massive hemothorax. As I said earlier, sometimes the aorta doesn't completely rupture, so you're not going to get the widened mediastinum, but what you may get is an aneurysm or a dissection type of injury that may be picked up on the CT scan. And then if there's an injury to the root of the aorta, which is, by the way, a very common place for the aorta to be injured, the root communicates with the pericardial space. So sometimes patients with aortic injuries, again, injuries specifically to the aortic root, can end up with a pericardial tamponade. So those would be some of the injuries that you may see when somebody injures their great vessels. Now, this is a surprise to me. I don't know about to you, but 30 to 50% of patients with aortic injuries will be asymptomatic. They'll have no signs of injury at all. And so that can make the diagnosis challenging. Now, of those who have symptoms, some of the symptoms that you may see with great vessel injury includes chest or back pain. And much like a dissection, the patient may describe it as a tearing, ripping chest pain. And then think about blood filling into the mediastinum. What symptoms would go with, a mediastinum full of blood? Well, dyspnea, right? As the trachea is compressed inside of the mediastinum. The vagus nerve runs through the mediastinum, so the patient may have vagal complaints. They may complain of syncope. You may see bradycardia. And then as the esophagus collapses inside of the mediastinum, the patient may also complain of dysphagia. Now, those were some of the subjective findings that would indicate somebody's got a great vessel injury. What are some of the objective findings? Of course, they could have significant blood loss with signs of hemorrhagic shock. The patient may also have asymmetrical pulse pressures. And this is actually a fairly common finding, but it's not something we do often in the clinical field. So let's talk about it for a moment. Look at that x-ray on the screen. You can see just after the aortic arch, the patient has an aortic injury, and you can see that defect there. So there's the injury, you can see the clotting and the blood accumulating inside of the aorta, right? Now as you get that blood clotting in that injured part, blood's going to back up behind it, right? The blood can't get around the injury, at least not as well as it can if there were no injury. So you've kind of got that occlusion forming in the lumen of the aorta, and that's going to cause blood to back up behind it, which means any blood vessels behind it may have a higher pressure because blood's being pushed back up into them. But because there's a obstruction forming in the aorta, less blood can get by, which means any blood vessels distal to the injury are going to have a decreased blood supply. Now, how would you pick up on that in the clinical field? Well, you may notice that the limbs behind the injury are going to be hypertensive because blood's backing up into them, and so there's going to be a higher pressure. But limbs distal to the injury are going to be hypotensive. So the way we would pick up on this is to do blood pressures in the various limbs and see if there's a difference in the systolic pressure. Normally, the systolic pressure between the limbs should be no more than 10 millimeters of mercury different. Okay, so they're very, very similar. But with an aortic injury, you may notice that one or even both arms are hypertensive, but the thighs are hypotensive. And anytime there's a difference of more than 20 millimeters of mercury between the limbs, between the systolic pressure of the limbs, you should have a high index of suspicion that your patient has an injury to the aorta. You know, I work with a nurse practitioner who works in a ICU up in Detroit. He actually works in a trauma ICU, and he tells a story about this that I think brings it home so well. But they had a patient admitted up to their trauma ICU from the emergency department who had chest trauma. And shortly after the patient arrived up in the trauma ICU, he began to deteriorate rapidly. Now, my colleague thought that the patient probably had a tamponade and was working him up as a tamponade. But when the attending physician arrived at the bedside, he immediately asked them to do 3 blood pressures, 1 in each arm, and then of course the thigh. And what they found is the difference between the arms and the thigh was nearly 60 millimeters of mercury difference. A very clear indication that there was an aortic injury. They were able to get the gentleman to the OR, and they were able to repair his aorta, right? So that's just a story of how asymmetrical pulse pressures can be used to identify a great vessel injury. Now, other things besides that you can use, listen for a bruit. Put your stethoscope either over the chest or even between the scapula and listen for the sound of a bruit, which would be heard over top of an aortic injury as blood rushes around that injured area. You can imagine a bruit in that patient that the x-ray is on the screen. Also, if there's any injury up around the top of the arch where the carotids branch off, you could have reduced blood supply to the carotids, which could lead to focal neurological findings or paraplegia, and the patient may have stroke-like symptoms. The laryngeal nerve is right up near the aortic arch, and it can be compressed if there's a large hematoma, leading to hoarseness. And then you may also hear a systolic murmur. So lots of things that might point to a great vessel injury, even if the patient themselves don't have any complaints. Now, overall, we're going to treat aortic injuries or great vessel injuries of any kind for that matter, much like you would treat a non-traumatic aortic dissection. Have you cared for a patient with an aortic dissection? Those are pretty scary patients, aren't they? They tend to deteriorate very rapidly, and we're always worried about that aorta rupturing. So there's always kind of that sense of urgency. Well, the same would be said for somebody with a known or suspected aortic injury in a trauma. You'll want to keep the patient calm and quiet, and we'll want to consider emergent surgical intervention. Now, if there's going to be a delay in surgical intervention for any reason, What we do want to do with aortic injuries is we want to lower that patient's blood pressure as much as is feasible to reduce pressure into the injury and prevent it from worsening and to try to slow down blood loss. Now, the good news is most of the time trauma patients are already hypotensive, so there's no need to do any intervention. But if you've watched the special considerations module, I talked about permissive hypotension. This is a perfect patient on which permissive hypotension would be appropriate, because the low blood pressure would reduce blood loss from the aortic injury. It would also reduce pressure on the aorta. So definitely consider permissive hypotension. Now, if the patient's not hypotensive, then we would consider a beta blockade, much like you would for any dissection. So, propranolol or labetalol may be used, but you want to titrate that drug to a systolic of 100 to 120, a MAP of 80, and a heart rate of 60 to 80. But again, that's rarely needed. You don't usually need the beta blockade here because typically your patients are hypotensive from the traumatic injury, so we'll just use permissive hypotension. All right, let's move on now from aortic injuries to a tamponade. The pericardial sac around the outside of the heart is designed to hold about 100 mLs of fluid. So you can comfortably get 100 mLs in there without any problem. Now, on healthy people like you and I, there's only about 20 to 40 mLs of pericardial fluid in there. So the sac isn't even full. Excuse me. The sac isn't even full. So we can get additional fluid into the pericardium without causing any problems. But once you get 100 mLs of fluid in the sac, it doesn't stretch much anymore, which means that everything inside, including the heart, is going to be compressed as fluid continues to build. And that's going to decrease filling of the heart during diastole. And that's really where the problem with pericardial tamponades come in, is you get an obstructive shock as the ventricles are crushed inside of the sac. Now, especially for slower bleeds in this area, your tamponades may be delayed because remember, there's only 20 to 40 mLs of fluid in the sac on a good day. They can hold up to 100, which means that if you have a kind of a slow leak into that sac, it's going to take a while for it to completely fill up and before the ventricles get compressed. So sometimes we'll see tamponades occurring after the patient arrives in the trauma unit and sometimes even after they're admitted up into the critical care unit. Now, the classic signs of a pericardial tamponade are known as Becks Triad. There's three components to Becks Triad, and when your patient has these three, you should have a really high index of suspicion for a tamponade. And the three are muffled heart tones, distended neck veins, and systemic hypotension. When your patient has those three, definitely work them up as a possible tamponade. Do note, however, that as few as 10% of patients may have the Becks Triad with a tamponade. Why is that? Well, distended neck veins do require a full blood volume, and many of our chest trauma patients who have a tamponade are bleeding and may not have enough volume for JVD. So you may see JVD, but in the face of hypovolemia, it may not be present. And muffled heart tones, they're muffled because, of course, the fluid, the blood is building up in front of the heart, so it's going to absorb some of the sounds that your stethoscope may pick up. So when you put your stethoscope over the chest, instead of lub-dub, you may hear the muffling. It's muffled behind the fluid. However, if you're working in a busy trauma room, who can hear muffled heart tones, right? Yeah, they may be there, but they're probably going to be very difficult to assess in a noisy trauma room. So you may get the components of Becks Triad, but just note that not everybody gets all three, even though they have a tamponade. Now, the EKG may be a better indicator that your patient has a tamponade. If you're watching this on video, look at that EKG. You may even want to pause the video for a moment. See if you can see the various changes in that EKG which kind of say tamponade. Can you see them? Let me give you a few of the indications. Tachycardia. One of the signs of tamponade is tachycardia, and that's because of the obstructive shock. The body's causing the heart rate to increase in an effort to improve oxygen delivery in the face of obstructive shock. So we see tachycardia in that video. We also see that the QRSs are fairly small. As a patient's tamponade progresses, the fluid in front of the heart is going to blunt the electricity that hits the lead on the chest. So the longer the patient is in the department and the more their tamponade develops, the smaller the QRS complexes get. But the other change you see in that EKG is what we sometimes refer to as a pulsus alternans or an electrical alternans. I think this is totally cool, but perhaps I'm a bit of a nerd, right? But what is an electrical alternans? Well, notice how every other QRS in that EKG changes shape. You got a small one and a tall one, a small one and a tall one, and they alternate. Now, why would that happen? Well, it's because when there's a lot of fluid in the sac around the heart's able to swing back and forth freely inside of the fluid. So as the heart swings forward towards the chest wall, you may get a taller QRS. And as the heart swings back away from the chest wall, you may get a smaller QRS. So you're actually seeing the heart swinging inside of the chest, and we call that a pulsus alternans. Some additional cardiovascular findings that go with the tamponade besides the EKG changes. Of course, your central venous pressures will be elevated. That's the obstructive shock and the blood backing up into the vena cava. Your pulse pressures may narrow. We talked quite a bit about that in the special considerations module if you haven't yet watched it. You may have a rapid falling cardiac output. You may have a pulsus paradoxus. Now be careful, don't get that mixed up with an electrical alternans. They're different things. A pulsus paradoxus is pictured on the bottom of your screen there now. But a pulsus paradoxus is where your blood pressure drops slightly during inhalation. Now, even with healthy people, this happens. I do not have a tamponade, obviously. But if I were to take a really deep breath in right now and hold it, and if you were to take my blood pressure would actually have dropped a couple millimeters of mercury after I inhaled. Why? Well, when you inhale, you have an increased intrathoracic pressure, which means that it's more difficult for the right ventricle to deliver blood to the left ventricle. So there's going to be a slight drop in systolic blood pressure when you inhale, and that's normal, that's healthy. But the drop shouldn't be more than about 3 to 4 millimeters of mercury on a healthy patient. Now, when your patient has increased intrathoracic pressures from any disease, like let's say COPD, for example, when they take a breath in, because the pressure is already elevated from COPD, it's going to drop even more when they take a deep breath in. And a tamponade is the same thing. With a tamponade, you have an enlarged amount of fluid around the heart that increases intrathoracic pressure. So it's already hard for the right ventricle to move to the left. And then when they take a deep breath in, they get a significant drop in blood pressure because the intrathoracic pressure climbs so high. So when the blood pressure drops more than 10 millimeters of mercury on inhalation, we call that a pulsus paradoxus. Now, this is not particularly a useful test because remember, most people with a pericardial tamponade are dying and they're probably in either severe respiratory distress or they're already unconscious. So how are you going to get them to hold their breath so you can take their blood pressure to see if it drops, right? That's almost impossible. So can we use pulsus paradoxus in the clinical arena? Well, yes, we can, but especially if your patient has hemodynamic monitoring or central monitoring started, especially, let's say, an art line. That's what you're seeing in that picture on the bottom of your screen there. You're seeing an art line along the top, and you notice how when the patient inhales, and that's shown on the bottom where inhalation is, notice when the patient inhales that the pleth of the art line gets smaller. Well, that would indicate the blood pressure is dropping, and that's because when they take a deep breath in, intrathoracic pressure climbs. It's harder for the blood to go from the right ventricle to the left through the lungs, so their pressure is going to drop when they inhale, and you can see it as a decreased pleth on the art line. But then when they exhale and there's less pressure in the chest, more blood gets to the left ventricle and the blood pressure goes up, and you can see that by an elevated pleth on the art line. So we can sometimes see a pulsus paradoxus if we're monitoring our patient's hemodynamic status. But to actually measure this at the bedside without hemodynamic monitoring, it's very difficult, if not impossible, to do. You could, however, have a question on the exam about pulsus paradoxus, so I hope that my explanation made sense. But let me finish with just a review. Pulsus paradoxus is a drop of systolic blood pressure of 10 millimeters of mercury or more on inhalation. And it's usually associated with any condition that increases intrathoracic pressure, including a pericardial tamponade. Make sense? Now, the other cardiovascular finding we may see with the tamponade is PEA. Remember from ACLS that one of the causes of PEA is a tamponade. Now, there are some non-cardiac indications of a tamponade as well. The one I kind of already mentioned to you, and that is the patients in extremis. They're sick. People with the tamponade are getting very poor oxygen delivery, so they're going to be sick. A gray death-like appearance, extreme anxiety, inability to lie supine, dyspnea, cyanosis. They tend to be very, very sick when they have a tamponade. Now, tamponades are one condition that we could actually use a FAST exam to diagnose. I talk a little bit more about FAST exams in the abdominal module of this series, so if you've watched that, you may have a little bit of a better idea about FAST exams. But remember, it takes about 100 mLs of fluid in order for a FAST exam to be positive. And a tamponade generally becomes symptomatic at 100 mLs or more of fluid. Therefore, FAST exams could be used to pick up a tamponade. Now, when a patient has signs of a tamponade or it's been diagnosed with a FAST exam, I think we all know the treatment is a pericardiocentesis, at least emergently. Putting a needle down through the bottom of the pericardial sac and withdrawing the blood or fluid off of the sac to relieve the obstruction. You see one pictured there on your screen right now. Now, today we can use ultrasound to guide the needle in, and that makes it a little bit of a lower risk procedure. But if for some reason you don't have ultrasound and the physician is having to guide the needle in blindly into the chest, the needle can inadvertently hit or even puncture the ventricle. And if that happens, you might see a little bit of ventricular ectopy on the monitor. So one thing that we can do from a nursing standpoint during a pericardiocentesis is just watch the monitor carefully for any ventricular ectopy, like a run of PVCs or some VTAC. And if we see it, we just want to make sure that the practitioner is aware of that so they can pull back on the needle a bit and try to move away from the ventricle. Now, many times a tamponade will continue to fill, so the needle may temporarily relieve the patient's symptoms, but if there's continued blood loss, the sac may fill with blood again, and then the patient becomes symptomatic. In those cases, an open thoracotomy may be necessary to open up the chest and make a small hole in the pericardial sac to allow that fluid to drain so that the patient doesn't get recurrent tamponades. All right, so that brings us to the next injury after tamponade, which will be a blunt cardiac injury. So this is a direct injury to the chest itself. Let me say it differently. That's a direct injury to the heart itself is what I meant to say there. Now, you should always suspect a blunt cardiac injury when your patient has external trauma to the chest, like you see in the picture on the screen with that seatbelt across the chest. You should also suspect it when the patient has significant rib fractures or sternal fractures. Now, as you can see in the drawing on your screen right now, the right ventricle is definitely the most vulnerable to a blunt cardiac injury. The right ventricle sits right here under the sternum. So blows to the chest from an airbag, from an assault, from hitting a steering wheel during a motor vehicle collision or anything like that, the right ventricle is going to slide forward into the sternum and potentially be injured. Now, the left ventricle is rarely injured because it's kind of here under your armpit, right? So if your arm is down, it's pretty hard to injure that left ventricle. So most of the time, injuries to the heart are going to hurt the right ventricle. Now, there's three main symptoms that you may see in a patient with a blunt cardiac injury. The first is chest pain. As you might anticipate, if your patient injures their heart, it's going to hurt, just like any muscle would hurt if you injure it, right? The key, however, is that unlike an MI, where you have radiating pain maybe into the jaw, shoulder, or other places, the pain of a blunt cardiac injury tends to be very specific to the area of the heart that was injured. It doesn't radiate. It stays at the site of injury. Also, it wouldn't respond to standard treatment that you might use for chest pain. You know, let's say you give the patient nitroglycerin or oxygen. Those would tend to reduce the pain of an MI. They won't reduce the pain of a blunt cardiac injury. However, can I just make an obvious statement? Don't give nitroglycerin to trauma patients. I mean, they're probably hypotensive. That's the last thing they need. But if you were to do it, it probably wouldn't help anyway. So chest pain is the first main symptom of a blunt cardiac injury. The second symptom is electrical disturbances. These occur because with time the heart swells, and when the heart swells it pulls at the electrical system of the heart, and that can lead to arrhythmias. The patient may also have ST segment changes, so you may see ST segment depression or even ST segment elevation, and then they can get arrhythmias related to the area of the heart that's injured. So if the atria are injured, there could be atrial arrhythmias. If the ventricle is injured, there could be ventricular arrhythmias. Do note, however, that the arrhythmias are really associated with edema to the heart, and that's going to be a delayed finding, right? So you may not see the arrhythmias immediately. They can occur sometimes, 12, 24 hours later. For that reason, people with known or even suspected blunt cardiac injuries should always be admitted to a monitored unit so we can monitor for delayed arrhythmias occurring after admission. Now, the third symptom that you may see with a blunt cardiac injury is heart failure. As I said earlier, the right ventricle is the one that's nearly always injured, so therefore we would expect right ventricular failure with these patients. So think about what symptoms a patient gets when the right ventricle fails. The blood backs up into the body from the right ventricle, right? Backs up into the vena cavas and then systemically. So the patient may end up with systemic signs of heart failure like JVD, hypotension, tachycardia, and with time you may start to see edema in the extremities as well. Now, like electrical disturbances, heart failure will tend to be delayed. The patient may not see that initially on arrival. That may occur on the inpatient unit hours later. Now, the treatment for the blunt cardiac injury is going to be revolving around those three symptoms. So for chest pain, we want to administer analgesia to the patient and then just do things like you would for an MI. You want to reduce workload on the heart. So reduce unnecessary stressors to the patient. Make sure the patient receives supplemental oxygen because that may help to reduce their pain. And other things that you might consider doing for an MI. Except, of course, fibrinolytics. Don't give fibrinolytics to a trauma patient. Now, for the electrical disturbances, again, the patient should be admitted to a monitor unit, and then if arrhythmias arise, they should be treated with antiarrhythmics as per ACLS protocols. For the heart failure, one of the biggest things we're going to see as the right side of heart failure sets in is hypotension. So the patient may require IV fluids as per their hemodynamic parameters to improve their cardiac output. Positive inotropes could also be used like dobutamine to improve cardiac output. So that brings us back to the challenge question that I started this module with. Remember that? The following rhythm strip is noted on the monitor of a traumatically injured patient. Which of the following injuries does this patient most likely have? Now remember, your choices were fractured sternum, cervical spinal injury, ruptured diaphragm, and pericardial tamponade. This is one of the more difficult questions that you may encounter on the exam because these are called analysis-based questions. And analysis-based questions are a little bit more difficult because in analysis-based questions, it's not pure recall. It's not that you just have to remember a fact, but you actually have to do some analysis in order to get to this one. And just over 20% of the questions on the TCRN will be analysis-based. So how do we have to do analysis here? Well, the first thing you have to be able to do is be able to read and interpret a two-lead rhythm strip. So look at that rhythm strip. What is the abnormality that you see on the rhythm strip? Do you see ST elevation? It's pretty obvious, right? You got the big tombstones. So the patient has ST elevation. Now, what is one of the causes of ST elevation? Well, a blunt cardiac injury. We just said it. So which of those choices on the screen is related to a blunt cardiac injury? And remember, I said earlier that it is a fractured sternum. Fractured sternums the sternum lies over the right ventricle, and so the heart can be injured with a fractured sternum, and if the heart is injured, you get ST elevation. We don't expect ST elevation with a cervical spinal injury, with a ruptured diaphragm, or with a tamponade. With the tamponade, I would expect things like electrical alternans and decreased height of the QRS, none of which we really see in that rhythm strip. Does that make sense how I got to that one? Did you get it right? All right, let's try another question. Ready? Effective ventilator management of the patient with acute respiratory distress syndrome involves lowering which of the following ventilator settings below normal? Again, can I recommend that you pause this and really think about the question? I'm going to move on. I'll give you the answer later, but you'll want to try to see if you get the question correct. Okay. Let's move on now from the heart to the pleural space. Remember, the pleural space is the potential space created around your lung, and it's in between the visceral and the parietal pleura. The pleura is, remember, lining around the outside of the lung, and you have two pleura. If you look closely at the picture on the screen, on the left-hand side, you'll see an enlargement of the pleura. Now there's one pleura that sticks to or adheres to the lung surface. That's known as the visceral pleura. And then above the, and then on the picture, by the way, it's colored in blue. Now above that is the second pleura, which adheres to the chest wall, and that's known as your parietal pleura. So you have the visceral pleura on the lung and you have the parietal pleura on the chest wall. Now the space between the two is called the pleural space, although you and I don't have a pleural space because we're healthy. There's a negative pressure in the pleural space that causes the two to be adhered to one another, and they kind of stick together, so there really isn't a space between them. But if you get any air or fluid into that area between the two pleura, it'll cause them to separate, and then you have a pleural space. So in trauma, the most likely thing to get between the two pleura would be blood in the form of a hemothorax, or if we have a tear in any of the pleura, either the parietal or the visceral pleura, then air can get into there causing a pneumothorax. So let's look at some of the causes of a pneumothorax. Nearly all pneumothoraces are caused by a pulmonary laceration. About 71% of pneumothorax come from a defect in the lung itself. Usually it's a ruptured alveoli. You're driving along, you're about to be in a motor vehicle collision. What will you likely do at the point of impact if you know what's going to happen? You're going to gasp, right? And when you gasp, you close your glottis. Then the airbag deploys on your chest and it pushes your ribs back. And when you push your ribs back, it squishes the lung. But because you've gasped, air can't get out of your trachea. So instead, the lungs get squished and the alveoli rupture. They pop. And when they pop, that communicates with the pleural space. So now when the patient takes a breath in, it goes down into that alveoli that's ruptured, and the rupture's into the pleural space, and air goes right out into the pleural space. And that then allows the air to separate the visceral and the parietal pleura, and the lung collapses. That was a really long explanation of a pneumothorax, wasn't it? But 71% of pneumos come about that way. Now, some other things that can cause pneumothoraces include tears in the esophagus and the trachea. Tracheobronchial tears account for about 13% of pneumothoraces, and esophageal injuries account for 9%. Now, rare but possible, you can also get a wound on the external chest wall that communicates with the pleura, allowing air to get from the outside in. We call that a sucking chest wound or an open chest wound. And the air is pulled from the chest wall into the pleural space as the patient tries to breathe. So you may hear this sucking sound as air is pulled through the hole in the chest on inhalation, and then as they exhale you may see bubbling in the blood around the wound, or even subcutaneous emphysema on the chest with these external chest wounds. And any wound on the chest wall can cause an open pneumothorax or a sucking chest wound, but we especially here think of things like gunshots, stabbings, but any trauma, even potentially a compound rib fracture, could cause a sucking chest wound on the chest. Now, remember that air always seeks the path of least resistance, always. So on your chest, if you get a hole in the chest, say from a gunshot wound, the distance between the chest wall and the pleural space is not that big. It's a pretty short space. Whereas if you're breathing in, air's got to go from your mouth, down your trachea, down your bronchi, down your bronchioles, and into your alveoli. And there's a lot of resistance when it goes in through the mouth and nose. So if you have a hole in the chest, when the patient goes to inhale, guess which route the air is going to choose to go into? It'll choose the chest wall, right? Because that's a really small wound with very little resistance. So air will tend to get sucked into the chest, and they'll take very little air in through their mouth. So now they end up kind of breathing through the hole in their chest. Now, of course, the problem with breathing through a hole in the chest, well, that air that they're taking in through the chest wound is not going to the alveoli for gas exchange. It's going to the pleural space where there's no gas exchange. So that's going to lead to profound hypoxia. So, of course, what's the emergent treatment for somebody with a sucking or open chest wound? You got to cover it, right? The minute you cover it, air will no longer be pulled into that wound, and the patient will now breathe fully through their mouth, and that'll immediately improve their oxygenation. So when you have a suspected or known sucking chest wound, get something over it. Even a gloved hand can temporarily be used to plug the hole. Now in the textbook they'll talk about using an occlusive dressing taped on 3 sides. So you want to leave that 4th side open so that if the patient gets a lot of buildup of pressure in the pleural space, supposedly the air can leak through the 4th side. Doesn't really work that way. It takes a lot of pressure to get out of that 4th side. So while it's a good theory, and that's how you should answer the question on the exam, do note that you may have to actually lift the dressing up during one of the cycles of the respiratory cycle to allow air out, and then put the dressing back down if the patient shows signs of attention pneumothorax. So let's talk about attention pneumothorax for a minute. Oh, and before, by the way, if I go back to that previous concept, when we talk about putting a dressing over top of an open chest wound, that's a temporary fix. The definitive treatment is of obviously getting a chest tube into that pleural space. Okay. Now let's move on to attention pneumothorax. So attention pneumothorax is where you have ingress of air into the pleural space, but you don't have egress. Think about that ruptured alveoli I talked about a moment ago, where the airbag pushes on the chest and ruptures the alveoli. So now you have a ruptured alveoli with a flopping alveolar wall, right? And when the patient takes a breath in, the pressure forces the alveolar wall open. That's that ruptured alveoli, forces the alveolar wall open, and air can pour out into the pleural space. But when they exhale, the alveolar wall collapses on itself, and that blocks the exit of the air from the pleural space. So each breath adds air, but then the air can't get out. Okay, so that's how you get attention pneumothorax. And then the side of the defect is going to get this massive amount of air building up that's going to push the collapsed lung and everything to the other side, leading to obstructive shock. So signs of attention pneumothorax can include severe respiratory distress, diminished or even absent breath sounds on the affected side, signs of obstructive shock, which by the way I talk about in the special considerations module of this series, so you can learn more about it there. The patient may get tracheal deviation. Now remember, as the chest fills with air, it's going to push everything to the other side, so the trachea is going to deviate away from the tension pneumothorax. So if you see tracheal deviation, which by the way is a very late finding, it happens very late in the process, but if there is tracheal deviation, it will always deviate towards the side that's not injured. The tension pneumo, it will be pushed away from the tension pneumo side. And then the patient may have signs of respiratory distress like cyanosis. Now I think we all know how to fix attention pneumothorax, right? You've probably taken this before, but it's to do a needle thoracostomy. At least that's the temporary measure to fix it. Now there's 2 locations that you can do a needle thoracostomy. The traditional one was the second intercostal space mid-clavicular line. So of course you got your clavicle. Now your first rib is up under your clavicle. You really got to push or jab into your chest to find the first rib. But the second rib is right below it, and that one you don't have to jab for. You can easily feel your second rib, and you can also, of course, feel your third rib. So you're going to put the needle between the second and the third rib, preferably right over the third rib. Use a large bore needle, like a 14 and 16 on an adult, or an 18 or 20 on a child, and you're just going to want to jab it straight into the second intercostal space in the middle of the clavicle. If there is a tension pneumothorax, there should be a rush of air and the patient's condition should improve. Now there is the mammillary artery that runs fairly close to that site, and there is a rare but potential that you could injure that artery and lead to blood loss. So for that reason, we are moving towards another site to do a needle thoracostomy, and that's the fifth intercostal space mid-axillary line. So under the arm at the fifth intercostal space and darted in there. Now the problem with that one though, of course, is now the arm kind of gets in the way. So neither of these are perfect, but those are two sites that you can do a needle thoracostomy. Now when you put the needle in, there should be a rush of air. The patient's condition should improve. You can take the needle out and just leave the Cathlon in until a chest tube is placed, and then once a chest tube is placed, the needle can go out. I'm going to show you a video now. And this is going to be one of those videos where you say, how did they get that video? And I don't know the answer. I just know there's a video. But when you watch the video, what you're going to see is you're going to see the needle come through the chest wall with the Cathlon. And then once the needle comes through and it comes in the top, they're going to pull the needle out but leave the Cathlon in. And then air is going to come out of the pleural space, and you're slowly going to see the lung reinflate and push up against the needle. It's a really cool video. And you get some free 70s porn music with the video. Ready? Here we go. Pretty cool, huh? All right, that's enough of pneumos. Now let's talk about hemothoraces. So on the screen, I've listed just some common sources of bleeding into the pleural space that can lead to a hemothorax. Now, a hemothorax can either be venous or arterial. A venous hemothorax is often self-limiting. In other words, there's bleeding from one of those veins, blood begins to fill into the pleural space, but because it's venous bleeding, as the intrathoracic pressure climbs, because there's blood accumulating there, it'll actually tamponade or slow the bleeding down. And sometimes we don't even need to treat a venous hemothorax. It may not require a chest tube or anything because it's just kind of self-limiting, so it'll just be a small amount of blood in the bottom. Now, if a large vein or an artery is torn, then the bleeding can be significant enough to lead to secondary complications and require a chest tube. A massive hemothorax, which is going to be related to an arterial bleed, is defined as more than 1,500 mLs of blood in the pleural space. Now remember, women have about 4 liters of circulating blood and men have 5 liters. So 1,500 mLs of blood in the pleural space, that's pretty significant. That can lead to significant hypovolemia, not to mention the space it's going to take up and the secondary tension hemothorax that may occur, and that will lead to obstructive shock. So let's just now compare side by side the signs of a hemothorax and the signs of a pneumothorax. So remember, blood sinks because it's heavy, whereas air rises. So a hemothorax, the blood's going to sink to the chest and often cause pain in the lower chest and the diaphragm area. Whereas a pneumothorax, air will rise, so the patient's more likely to complain of pain in the shoulder, especially when they take a breath in. That's referred to as pleuritic pain. Fremitus, remember this from nursing school? Try this. Put your hands on your chest and say something. You can feel every word you say, right? There's that gentle vibration on your chest that's called fremitus. Now, fluid will absorb fremitus. So if I were to put my hands over my patient's chest with a hemothorax and ask them to speak, I may not feel any sound waves because the blood in the hemothorax will absorb the fluid, or will absorb the sound waves from into the fluid. Now, if I put my hands over a pneumothorax, I may still feel some fremitus because it will have some vibration through the air of the pneumo. Now, breath sounds are going to be decreased over both. If you percuss, good for you, whatever. Anyway, you'll notice if you percuss over fluid down here in the hemo, you're going to have hyporesonance or dullness to percussion. Whereas if you percuss over a pneumothorax, you'll have hyperresonance or tympany. Egophony, remember this from nursing school? Egophony is where you put your stethoscope on the chest and you ask the patient to say the letter E. Now normally, when you say the letter E, it's transmitted through the lung and it sounds like E. That's what you'll hear in your stethoscope. However, if there's fluid in there and you put your stethoscope over the fluid, when you ask the patient to say E, the fluid will bleat the sound and it will sound kind of like an You're going to get that bleeding A sound. That's called egophony. So egophony is present over a hemothorax, but not present over a pneumothorax. So, how do we treat these different conditions, hemothorax and pneumothorax? Well, the first thing you have to determine is your patient stable or not? If the patient has a really small pneumo, maybe a 10% or even a 20% pneumo, but it's self-contained, it's not getting worse, their SATs are good and they're stable, we may not even put in a chest tube. In fact, what we may just do is put them on 100% O2. Now, what happens with the 100% O2 is it actually helps to get rid of the pneumo, and let me explain why. Right now, you're breathing room air. Remember, room air is 21% oxygen and 79% nitrogen. When you put somebody on 100% O2, obviously they're breathing in all oxygen. There's no nitrogen in 100% O2. So when you're breathing room air, you take in the 21% oxygen and the 79% nitrogen, and the 21% oxygen diffuses across the alveolar membrane and goes into the blood, but the 79% nitrogen does not diffuse. It stays in the alveoli and it keeps the alveoli open. Whereas when you give somebody 100% O2, what's going to diffuse? Everything, right? Because oxygen diffuses. So if it's 100% O2, all of the oxygen diffuses and leaves the alveoli empty. There's no nitrogen to hold the alveoli empty. So with 100% O2, your alveoli is empty. And then what's going to happen is that's going to create a vacuum or a negative pressure when the alveoli empties, and that vacuum will pull the air from the pneumothorax into the lung. And then when you pull that air from the pneumothorax into the lung, it helps to expand the lung. And generally, within a short period of time of putting somebody on 100% O2 with a small pneumo, you can re-expand the pneumo. And if the defect or hole that caused the pneumo is really small, it just may seal itself off and no further treatment is needed. So 100% O2 is the mainstay of treatment for a really small pneumo that's fairly asymptomatic. Now, the same can be said for a small hemo. If it's a little venous hemo and there's 100 or 200 mLs of blood collecting, we may not put in a chest tube. We may just simply observe the patient, encourage deep breathing, and the blood can then reabsorb. Now, for both of these, though, if you're not putting in a chest tube for a small hemo or a small pneumo, you will want to observe the patient for deterioration because they can get worse and they may need a delayed chest tube. Now, if your patient is in any way, shape, or form unstable, then a chest tube needs to be placed. While we're waiting for chest tube placement, you'll want to support the patient with supplemental oxygen or sometimes even intubation. And for a really large hemo that's arterial, where you got like that 1,500 mLs of blood or whatever, a thoracotomy may be required. Now for your large hemos, you're also going to need to give them fluid replacement, treat hypovolemic shock, and then consider autotransfusion for the really, really large hemos. Let's talk about autotransfusion for a minute. So what are the advantages and disadvantages of autotransfusion? Well, before I get into that, let's just make sure everybody's aware of what autotransfusion is, because I know not every hospital does it, but it's pictured on your screen. Autotransfusion is taking blood from the chest, putting it in a blood bag directly out of the chest drainage set, and then rehanging it on the patient. So you're giving them their own blood back from their chest. Now the advantages of doing this in a chest trauma patient is that you don't have to wait for the blood bank. The blood's there, it's right at the bedside, you just have to hang it. And I love that second point. There's no incompatibility concerns. If you give incompatible blood using an autotransfusion device, there's something really wrong with your hospital. We might probably need to close your hospital down. So obviously the blood in the patient's chest drainage set is going to be compatible. Now in the special considerations module, I talk about some of the negative effects of blood transfusions like hypocalcemia, acidosis, hypothermia. Well, guess what? Those problems don't exist with autotransfusion because it's the patient's own blood and it's fresh. So you kind of reduce the complications of blood transfusions by using autotransfusion. And if the person has a religious objection to a blood transfusion, they may accept autotransfusion because it's on a closed circuit. Now there are disadvantages to autotransfusion. It is limited to non-contaminated wounds. If the patient has a gunshot or a stabbing, the blood in that pleural space is probably contaminated with bacteria because the wound is open. So if I take that blood and put it back in the central circulation, I introduce the bacteria back to the central circulation. Not ideal. Is it sometimes done? Yes, it is. We do autotransfuse even with an open wound, but we do have to recognize that we've created the high potential for infections and sepsis when we do that. It does require special equipment and operator training. Not every hospital is equipped to do this. And generally, you wouldn't want to use blood that's been in the chest drainage set for more than 4 to 6 hours because bacteria thrives in blood. And if it's been sitting there, it probably has bacteria. Can I say, however, that if your patient needs an autotransfusion and they've been there 4 to 6 hours with a chest tube, again, there's something really wrong with your system. Generally, autotransfusion is reserved for patients who are actively dying, and we're using this as a life-saving measure in the few minutes it takes to get them to the OR for an open thoracotomy and repair. So they're probably not sitting there 4 to 6 hours, right? All right, let's divert a minute and talk a little bit about caring for the chest drainage system. So just some basic principles, nothing too earth-shattering here, but make sure that the chest drainage set is always maintained below the level of the chest because you don't want any backflow into the chest, and we also have to maintain patency of the chest. Keep the unit upright. Prevent dependent loops. If you're watching this on video, look at that picture. That should make you shudder a bit when you see the picture. Look at the tubing sitting on the floor. The tubing's down below the chest drainage set. So now the blood's got to go up into the chest drainage set. That's not easy to do. It's maybe even impossible. So that blood's going to sit there. It's going to grow bacteria. It could develop into a clot. Don't do that. Make sure that the tubing is looped on the bed and drops straight down into the chest drainage set so that blood drains directly away. And then never clamp the tubing because it can put a negative pressure back into the pleural space and re-expand the pneumo. Only under extenuating circumstances, like say the chest tube gets dislodged, would you even consider clamping the tubing. Now let's talk about the chest drainage set itself. I want to talk first of all about traditional chest drainage sets, or in other words, ones that have a water suction chamber. I know most of you today do not use water suction, but if we understand it on an old chest drainage set, then I can easily transfer it over to the newer waterless systems, okay? So remember, in a traditional set, you had 3 chambers. There was the collection chamber. In the picture on your screen, that's letter A. There was the water control chamber, or water seal chamber, I should say. And in your picture, that's B. And then in a traditional set, there was the suction chamber, which is C. So A is the collection chamber, B is the water seal chamber, C is the suction chamber. Now, should there be any bubbling in the collection chamber, letter A? I hope you said no. Of course there's no bubbling there. That is just a collection chamber. So as the blood exits the chest, it's just simply going to rise in the collection chamber. Should there be bubbling in B, the water seal chamber? Well, the answer is yes, but, so make sure there's the but on there. Yes, but. So you may see some bubbling in B, the water seal chamber, but that bubbling should be intermittent, not continuous. When in the respiratory cycle should there be bubbling in the water seal chamber? During inhalation, right? Because during inhalation, the lung comes up towards the top of the chest wall and pushes air out of the pleural space. And as it's pushed out, it bubbles through the water seal. So there should be bubbling on inhalation only. There should not be bubbling on exhalation. Now on exhalation, as the lung falls back down, it's going to pull backwards and it may actually lift the column of water up a little bit. We call that titling. So you may see the water column go up and down, up during exhalation, down during inhalation, and then during inhalation there may be a little bubbling. That would be considered normal in the water sealed chamber. Now, if it's a water suction, should there be bubbling in C? Yes. Not only should there be bubbling, there should be continuous bubbling because the suction is being pulled through the water, so that it should continuously bubble. If there's no bubbling in C, then the suction ain't working. Now, of course, today most of us use waterless systems for suction, so instead of water in C, there may be bellows, and the bellows should be pulled out or inflated, and that's the way you determine whether suction is working on a newer chest drainage set. Now, let's say in the water seal chamber, which was letter B, you had titling, it was going up and down, and there was some bubbling in the water during inhalation, and then suddenly all of that stopped. No more titling, the water's just sitting there. No more bubbling. What problem solving should you consider at this point when titling and water and bubbling stops in the water seal chamber? If you haven't thought of several reasons, you might want to pause because I'm going to give you answers, but see if you can come up with these yourself. But let me give you some of the things that may cause titling to cease or bubbling to stop on inhalation. The first and most likely cause is the tubing is kinked. So, if you look at the chest tube and follow the tubing down to the chest drainage set, did the patient lie on it? Did they roll over and kink it off? Or did somebody put the bed rail down on the chest drainage set and kink it off? If it's kinked, that's going to stop the titling and the bubbling. So you'll just want to make sure that the tubing isn't kinked. Just follow the tubing all the way down to the patient. The second thing that can cause these things to happen is an obstruction or clot in the tubing. Okay? So especially if the tubing loops down below the chest drainage set and the blood sits there, it can clot. That'll occlude the tubing, and then it will stop the titling. Of course, to fix that, it's pretty easy. You just lift the tubing up and let the clot fall down into the chest drainage set. Now, the third reason is that the pneumothorax is re-expanded. Once the pleural space is gone, once the two pleura touch, because the pneumothorax is re-expanded, then the pleura is going to block the holes in the end of the chest tube and prevent air from getting in there, and then you won't see any titling or bubbling. So it could be that the pneumo has re-expanded. Now, let's talk about the opposite. Let's say that instead of the titling stopped, you get continuous bubbling in the water seal chamber. What things should you do when you see continuous bubbling in the water seal chamber of a chest drainage set? You should be able to come up with 4 things you should do. So if you can't think of the 4, pause this and see if you can come up with the answer, because I'm going to give them to you now. So the first thing that you may see, or the first thing you should consider, I should say, when the continuous bubbling is noted in the water seal chamber, is to check for an air leak at the site. As a flight nurse, I have to put in chest tubes. So look at my finger. It's pretty stubby and fat, right? So when I make an incision and I tunnel my finger up through the ribs into the pleural space to make a hole for the chest tube, the hole's got to be at least as big as my chubby old finger, right? And so that's going to be a fairly big external hole. Now when I go to push the chest tube in, the chest tube will be smaller than the hole. It has to be to fit, right? So if I don't push the chest tube up far enough to make sure that the holes or fenestrations are way up in the pleural space, if the fenestrations are close to my finger hole, then air can be sucked through the finger hole into the fenestrations and then come out as a continuous bubbling. So the first thing you should think about when there's continuous bubbling in the water seal chamber is that there's a leak at the insertion site from the hole being too big and the fenestrations being far too close to the chest wall. You know, when I'm working in the hospital, I often find that residents especially are a little timid in putting in chest tubes, not aggressive enough. They don't push them up far enough, so the fenestrations end up down by the entrance site, and then there's a lot of bubbling. So what I try to do is get the resident to not suture the chest tube until I've hooked the chest tube up to the chest drainage set. Just have them hold it in place. I get the chest drainage set going. If there's continuous bubbling, I tell them to push the chest tube up like 3 or 4 more inches. Just push it in a little bit further. That's often all that's needed to stop the bubbling. And then once you got the bubbling stopped, they can suture it. Now, if the chest tube's already sutured and there is bubbling, then of course you would have to put a dressing at the site, an occlusive dressing, to prevent air from being sucked into that area. So the first cause of an air leak is at the insertion site. The second most likely cause of an air leak, which would cause continuous bubbling, by the way, is that the connections between the chest tube and the tubing are loose. They're not tight enough. Sometimes you can just push them in a little bit tighter, or you could wrap waterproof tape around the connections, and that may stop the bubbling. But if that doesn't stop it, the next thing you should consider is that there's either a hole in the tubing. Yeah, somebody drove over the tubing on the way to CT and put a little hole in it, or you have a defective chest drainage set. Now, how would you know if there's a hole in the tubing or a defective chest drainage set? Does anyone remember how to test for that? With a clamp, right? You may consider temporarily and for a very brief period of time clamping the tubing. Now, generally you're going to clamp it right at the point where the tubing enters into the chest drainage set, and you're going to clamp it. Now, if you clamp the tubing and it stops bubbling, then that indicates that you have a hole in the tubing somewhere, and you'll need to change out the tubing. How many of you went to nursing school a few years ago and were taught that you should clamp the tubing every inch to see where the hole is? Is that not the silliest thing they ever taught us? I mean, who cares if the hole's at the top of the tubing or the bottom? You're going to have to change out the tubing regardless of where the hole is. So why am I going to waste my time doing it every inch? The only thing that's going to prove is where the hole was, but I don't care where the hole is. I just need to know there's a hole and change out the tubing if there is one. Now, if I clamp the tubing and it still bubbles when I clamp it, then I know the problem's in the chest drainage set, and I'm going to have to change out the chest drainage set. Okay, I'm really going to throw one at you now. Let's say you did all of that. You built up the dressing, and you taped the connections, and you changed out the tubing and the chest drainage set, and it's still bubbling. I mean, the bottom line is at this point you have a patent chest drainage set with an air leak. Does anyone know what would cause an air leak in a patent chest drainage set? Well, the answer is it's something internal to the patient. When the patient has a large hole, like an esophageal or a tracheal or bronchial tear, those large holes can allow air to be pulled directly from the large hole into the chest tube and give you a continuous bubbling. You're generally not going to see that with small, like alveolar ruptures, because they're too small. But a large defect like a tracheal tear or an esophageal tear, those may cause continuous bubbling. And that's actually an indication for surgery. So if you got this patient with an air leak and continuous bubbling and you've problem solved and it's still there, yep, time to call the surgeon. Somebody needs to go to the OR. And it's not you, it's your patient. Okay, that's enough of the pleural space. Let's move on now to the lungs and talk about injury to the lungs. And I specifically want to look at a pulmonary contusion here. So a pulmonary contusion, as the name implies, is a bruise to the lung itself. It's a rupture of pulmonary tissue allowing blood to leak into the lung parenchyma and then ultimately into the airways and even the alveoli of the lungs. Now there's two main effects you're going to have of pulmonary contusion. You're going to get that bleeding that, again, initially starts in the lung parenchyma, but over time the blood will begin to accumulate in the alveoli. And then the blood congeals over time, and the congealed blood prevents gas exchange in that alveoli. So we're going to have an alteration in blood gases. But also, the injury to the lungs themselves are going to cause an inflammatory response. Now, if you're not familiar with that term, I talk a lot about it in the Special Considerations module, so make sure you watch that. But remember, with an inflammatory response, which is due to tissue injury, you get a capillary permeability. So not only now does the patient have blood in the airways and blood in the alveoli reducing oxygen exchange, but the inflammatory response is going to lead to a secondary capillary permeability with plasma accumulation in the alveoli. And pretty soon the alveoli are filled with congealed blood and plasma, and there's a reduction in gas exchange. And people with pulmonary contusions can have pretty significant decreases in their oxygenation, their PaO2. Ultimately, they're going to end up with a ventilation perfusion mismatch and shunt. Now, pulmonary contusions tend to be a more delayed injury. It's not necessarily present immediately at the time of resuscitation. The injury is there, but the symptoms may take as long as 6 to 48 hours to develop. So this is more likely to show up in the critical care unit after admission. The patient's going to have a reduction in the PaO2 as the blood and fluid accumulates in the alveoli. They may have hemoptysis. They may have increasing signs of respiratory distress, pleuritic chest pain, as fluid accumulates in the airways, crackles, severe hypoxemia and respiratory acidosis. They may have a cough as fluid builds up in the airways, but they can't get it out. When I say that, they can't get the fluid out. Local areas of wheezing as the airways are narrowed by the fluid. And if they're on a ventilator, increasing plateau pressures as the alveoli fill with blood and fluid. That's a pulmonary contusion. Now, the goals of treatment for a pulmonary contusion, the first is pain relief. The goal, again, like we talked about with rib fractures, is to make sure the patient is willing to and can cough to get those secretions and that blood out of there. One of the disadvantages of intubating a patient with a pulmonary contusion is they don't cough anymore, so they can't mobilize those secretions. So if possible, we don't intubate them, but we do aggressive pain relief so they can cough and get rid of the stuff in their chest. Here we are again with euvolemia. Don't over-resuscitate, because the extra fluids from over-resuscitation are going to contribute to that pulmonary edema. And then to ensure the patient has adequate respiratory gas exchange, use supplemental oxygen and either non-invasive or invasive ventilation if necessary. Preferably non-invasive so the patient can cough. Now long-term, we again want to make sure we mobilize secretions and blood through early chest physiotherapy, postural drainage, and early mobilization. Now I want to talk about acute respiratory distress syndrome to bring this section to a close, ARDS or ARDS. Now ARDS is a complication of chest trauma or just trauma period that is really related to the inflammatory response that I talk about in the Special Considerations module. So when the patient has significant tissue trauma, the body's going to release inflammatory mediators. Now, as I talk about in Special Considerations, those mediators have three main courses of action. They vasodilate, they increase capillary permeability, and they increase coagulation. So the increased capillary permeability in the lungs is going to lead to pulmonary edema and fluid sequestration. And the patient's going to get fluid in the lungs. Now, note that this is not a heart failure. I know heart failure causes fluid in the lungs, but these patients, their heart may be perfectly healthy, but the inflammatory mediators are causing fluid to build up in the lungs. As that fluid builds up, they become hypoxemic and they can develop a pulmonary hypertension. Now, as the fluid accumulates in the lungs and the inflammatory mediators are active in the alveoli, they begin to damage the alveolar surface, and the patient develops alveolitis. And the lungs, especially the alveoli, become stiff and fibrotic, and they don't stretch. So now you have these alveoli that won't stretch during inhalation anymore. The fluid sets up a foci for infection, and the patient gets secondary respiratory infections and pneumonia. And on the end, you have a pulmonary edema with stiff, non-compliant lungs, creating high pressures on the ventilator and possible secondary infections. And the patient can very well die from ARDS. Now, ARDS is often part of the multi-organ dysfunction syndrome cascade that I talk about in special considerations. This is the lung component of MODS. So how does ARDS tend to work? Well, many times ARDS is going to be delayed by several weeks post-trauma. It's not necessarily going to happen on day one, but several days or weeks after trauma, the patient begins to have an inflammatory response and fluid begins to accumulate in the lungs. Now, initially, the patient's physical assessment may be normal, although they'll become increasingly dyspneic as this process starts. Now, in the earlier phases, they may be able to maintain their PaO2, but as they become dyspneic, they blow off the CO2. So we often see an early respiratory alkalosis. The chest X-ray is often normal in those early periods of ARDS. But typically within 24 hours of onset of ARDS, the lungs just fill with fluid, the patient's oxygen levels rapidly drop, and they become increasingly dyspneic and get into a lot of trouble. They can have a markedly decreased oxygenation. As the lungs fill with fluid, they develop a hyperdynamic state and their cardiac index may elevate. Now the X-ray is going to show massive pulmonary edema, yet the cardiac silhouette will be normal because this is not a cardiac failure. So you have a normal sized cardiac silhouette with significant pulmonary edema. Physiological dead space will increase as the airways fill with fluid, and it will take higher and higher levels of PEEP to maintain any degree of oxygenation in the blood. Now there's two outcomes from ARDS. The first outcome is that the patient survives. There's a resolution. Now, unfortunately, the fibrosis of the lungs that occurs with ARDS will often leave these people with some degree of lung damage, and they may have respiratory insufficiency even after they're discharged following ARDS. Other patients will continue into severe failure and develop severe fibrosis of the lungs. They become stiff. We can't appropriately ventilate them anymore. Their oxygen levels become precipitously low, dangerously low, and ultimately they will probably die of poor oxygenation. Now, they often have other organ failures as well at this point. They may have coagulopathies or liver failure or renal failure. It's all part of the MODS process. So all of these combined together, some of these patients will die due to ARDS. So the classic findings of ARDS, the kind of the defining parameters that indicate ARDS are its acute onset. It comes about very quickly, usually 48 hours or less. The obvious bilateral infiltrates on X-ray, the severe pulmonary edema with a normal cardiac silhouette. The heart is not enlarged. Look at the X-ray on the screen right now. Severe pulmonary edema, yet that heart is not enlarged. And then the patient may have a PF ratio less than 300. Now, for those of you who don't work critical care, PF ratio may be a very unfamiliar term to you. So let's talk about the PF ratio. The PF ratio is a ratio of the patient's PaO2 to their FiO2. Said differently, a PF ratio is kind of an indirect measurement of how much oxygen is able to cross the alveolar membrane. So what we're doing in a PF ratio is we're looking at the amount of oxygen we give the patient, that's their FiO2, and we compare it to the amount of oxygen in their blood. That would be the PaO2. Now, if the alveoli is working, those should be fairly equal because the amount of oxygen that you give the patient should cross the alveolar membrane and get in the blood, so you should have kind of equal amounts on both sides. But in ARDS, the alveoli becomes fibrotic and doesn't allow oxygen to cross, which means you're going to have a higher FiO2 than a PaO2 because the alveoli is blocking the movement of oxygen. So that's how a PF ratio can be used to determine the onset of ARDS and the severity of it. So let me show you how to do a PF ratio. Let's look at that first patient on the left. She's healthy. Her lungs are not affected by ARDS. Now, what's normal PaO2 in a healthy adult? Probably close to 100, especially when we're younger. It gets a little lower as we get older, but still kind of 90 to 100. Now, that girl on the screen is breathing room air. So what's her FiO2? Well, 21%, because room air has 21% oxygen. So her FiO2 is 21% and her PaO2 is 100. So if we do some simple math, if you take their PaO2 and put it at the top number and then divide it by the FiO2, you're going to get the PF ratio. So 100 divided by 21% is 476. That's great. If you can get somebody's PF ratio above 400, that means the alveoli are working and they're helping to transmit that, transmit all of the oxygen into the blood. Now look at your sick patient on the right-hand side of the screen. His PO2 is 100 as well, and that would seem healthy. If you see 100, you should say, wow, that's great. But then when you look at his FiO2, it's not great, because he's on an FiO2 of 80%. So he's getting 4 times more oxygen than the girl. The girl's at 21%, he's at 80. So he's getting 4 times more oxygen. So if his alveoli were working, what should his PaO2 be? It should be 4 times higher, right? Because he's getting 4 times more oxygen. So I would expect a PaO2 of around 400 on him. But his PaO2 is only 100, which tells me what? That only a quarter of his alveoli are allowing oxygen across. 75% of his alveoli are no longer functioning. He's in trouble. Now, I can figure this out by doing a PF ratio. If I took his PO2 100 and divided by 80%, I get 125. That's an indication of pretty significant ARDS. That is telling me that he's not getting oxygen across the alveolar membrane. Generally, a PF ratio above 400 is considered healthy, and we don't generally have to intervene. Mild ARDS is defined as a PF ratio of 2 to 300, moderate ARDS is 100 to 200, and severe ARDS as less than 100. Remember, our gentleman on the previous screen was 125, so he's got pretty significant ARDS. So what's the treatment for ARDS? Here it is again, euvolemia. We don't want to give the patient too many fluids during resuscitation because those fluids provide fuel for the ARDS. They give the fluid to accumulate in the lungs. A positive fluid balance in the first 96 hours of admission with trauma is associated with higher rates of ARDS. Only give the patient the fluids necessary to stabilize them, but never give excess fluids. Now, the mainstay of treatment for ARDS will be appropriate ventilator management. As the lungs become stiff, the patient will not be able to tolerate higher tidal volumes. The higher tidal volumes can injure the lungs or even rupture the alveoli, giving a pneumothorax. So as the lungs become stiff, we're probably going to find we have to use lower tidal volumes. Now remember, we often set tidal volumes at around 8 mLs per kil when we intubate a healthy person. But with ARDS, we're going to have to start turning the tidal volumes down, and sometimes we even go subnormal. And we provide a lower tidal volume, which in turn could cause an elevated CO2, but we accept that CO2. We call that permissive hypercarbia. Now, the way that we try to get oxygen levels up with ARDS is to elevate the PEEP, and we'll use as high of a PEEP as we can get without affecting the patient's blood pressure. We may use PEEPs in the 15 to 20 range in really severe ARDS. Other things besides appropriate ventilator management include inhaled nitrous oxide, prone positioning, and ECMO. And we'll talk about those here in a moment. But let's answer the question that we started with. Effective ventilator management of the patient with ARDS involves lowering which of the following ventilator settings below normal? Did you get this one right? If you picked B, that is the correct answer. Remember, we want lower tidal volumes. Now, as we turn the tidal volumes down, we may have to turn the respiratory rate up in order to manage CO2. So CO2 would go up. And of course, we already said that PEEP would go up. We'd have to use higher levels of PEEP. Now, we tried not to turn the FiO2 up, but if we have to, we may have to increase the FiO2. So the only one we're going to decrease is the tidal volume. Just mentioning prone positioning in passing, this is used very effectively for some patients with ARDS. Now, why would putting somebody on their stomach improve their condition with ARDS? Well, it's twofold. When you lay on your back, your heart squishes your left lung, and it decreases the amount of oxygen that can be exchanged in the left lung. So if I lay you on your stomach, your heart falls forward against your chest wall, allowing your left lung to open more, and that may improve oxygenation. But also, if my patient's always laying on their back, and we know that a lot of intensive care unit patients are laying on their back, the fluid of ARDS is going to accumulate on the back, and you're going to get more fibrosis and stiffening in the back part of the lungs. Now, if you're on your back, gravity is also going to naturally pull blood to the capillaries in the back of the lungs. So now what you do is you have the most blood flow around the alveoli that are the stiffest and the most non-compliant. But if I flip you over on your stomach, gravity is going to pull the capillary blood to the front where there's less fluid and less fibrosis, and that can improve oxygen exchange. Some patients respond very well to prone positioning, and their oxygen levels improve as soon as you flip them over on their stomach. Now, lying on your stomach may not seem like a big deal, but you have to remember that these are really sick patients. They may have abdominal wounds from abdominal surgery, they could have chest tubes, they could be intubated. Flipping them over isn't necessarily easy. There are special beds to facilitate this, and it often takes a lot of staff to flip patients over. Now, some patients will be flipped over for a short period of time and flip back. Others will spend 6 or 24 hours on their stomach before they go back. It just depends upon your hospital policy, but you'll spend some time on your back and some time on your front with prone positioning. Some contraindications to prone positioning. Now, when I say, I'll start with relative contraindications, which means that we may still do it, but there is a risk factor to do it. If your patient has elevated intracranial pressure, we do know that prone positioning can elevate ICP. If your patient has interstitial edema or obesity, it may make prone positioning more difficult, and so we have to consider whether it's appropriate. And then recent abdominal surgery, it can be more difficult to lay someone on their stomach with abdominal wounds, especially if they're still open. Now, some absolute contraindications. So this is when you should not use prone positioning. If there's spinal cord instability, unstable fracture, facial fractures, burns to the anterior abdomen, an open abdomen, increased abdominal pressures, or unstable pelvic fractures. I also want to mention ECMO in passing, extracorporeal membrane oxygenation. Now, if you do this in your facility, you're probably very familiar with it, but a lot of facilities don't do this. Basically, an ECMO machine replaces the function of the heart and lungs. So we cannulate the patients, and we cannulate the patient twice, one in a vein, one in an artery. Blood is pulled out of the venous cannulation and it's put through the ECMO machine. The ECMO machine propels the blood and it helps to exchange oxygen and carbon dioxide in the machine. And then they put it back in through the arterial line. So basically you're replacing the function of the heart and the lungs with an ECMO machine, and the ECMO can effectively get carbon dioxide out of the blood and put oxygen in. So in a way, when a patient's on ECMO, they don't need their lungs anymore. We may actually turn the ventilator down or off during ECMO to rest the lungs and allow them to heal. But if the lungs are full of fluid, an ECMO machine will oxygenate the blood externally so that you don't need to use the lungs, and we can turn the ventilator down or off, rest the lungs, allow them to heal. The hope is if the lungs can improve, then we can take the patient off the machine and return the circulation to the patient. Now, the one thing is you are propelling blood through a machine that's going to have pumps that's going to potentially cause blood clots. So we do have to anticoagulate these patients, and that can be a risk in a patient who's already a potential for coagulopathies. So you'll need to monitor your patient's coag studies carefully when they're on ECMO to make sure they don't develop bleeding issues, and then watch for signs of bleeding. You also are cannulating the skin, so there's a higher rate of infection. And that is ECMO. That is also everything we have to talk about the chest. Now, I do want to mention the diaphragm before we close down here. The diaphragm, can be ruptured, and even though that's more of an abdominal injury, it does allow the abdominal contents to spill up into the chest. So the diaphragm, it's not a thick muscle. It's actually fairly thin, but it's a strong muscle. However, with a lot of intra-abdominal pressure, like an assault to the abdomen or an airbag deploying into the abdomen, can push the abdominal organs far enough back that they have to be displaced. Now, they can't go down because your pelvis is fixed, so the organs will go up, they'll tent the diaphragm, and with enough tenting, they'll tear it. Almost always on the left, because the right has the liver, which protects it, but the left also has an esophageal hole, which weakens it. So then the abdomen can spill up into the chest. Look at the x-ray on the screen right now. You can see loops of bowel up at the nipple line where the bowel has spilled up into the chest. Now, signs that your patient has a ruptured diaphragm, well, as the abdominal contents go into the left chest, it's going to push the heart over to the right, so you may hear heart sounds on the right side of the chest and bowel sounds on the left side of the chest. There could be signs of obstructive shock. The esophagus may get twisted, leading to dysphagia. Of course, all the abdominal contents in the chest can result in dyspnea. And then the patient may complain of pain in the shoulder, chest, or upper abdomen. If your patient does have a ruptured diaphragm, they will require surgical intervention. There, that's chest trauma. So best of luck on your studies, everybody.